I'm now going to hand over to Mark Britnell, who's our keynote speaker this morning. Mark is chairman and partner of the global health practice for KPMG, and he has a book, which I've just been told was it won the 2016 British Medical Association Award for the best health and social care book.
That's a recommendation.
And Mark has worked all over the place at national, local, regional level. You can read about his CV in the course book. So, Mark, over to you.
Can you all hear me? Can you see me? Yeah. Okay, I'm fine. Thank you. I'm fine. Thank you. Good morning, everybody. I'm Dr Mark Britnell. I'm the Global Chairman for Healthcare for KPMG. As you can see here, I'm also one of the 15 members of the World Economic Forum Health Council. And every year we get the opportunity, 15 of us, to try and speak truth to power in Davos. And this year we produced a document. Some of you may have seen it. I don't think it's been widely circulated. But my colleague at Harvard, Professor David Bloom and KPMG, decided to test a hypothesis. And if you don't remember anything else I say in the next 15 minutes or so, I'll leave 5 minutes, James, if that's okay, for Q&A. Our central hypothesis is we can do more good for the world in terms of accessible and affordable healthcare if we change our business models and adopt new therapeutic and technological advances. And that hypothesis was tested over 18 months with our global healthcare team. I'm not going to plug KPMG. We've been going for 140 years. We operate in 157 countries. And basically, oh, did I? I'm so sorry. Basically, with Harvard and a central coordinating team from the World Economic Forum, we produced a piece of work which we used to try and challenge the prevailing political consensus. Now, we all know that healthcare consumes more resources every decade or so in the developed world. GDP rises by about 1.4% every decade to accommodate advances in therapeutics, in technology, and indeed, as James said, aging. But when you look at misalignments in healthcare, and when I refer to misalignments in healthcare, I mean the misalignments between payer, provider, pharma and patients. When you look at those misalignments, the waste in the system is truly phenomenal. Now, before I show you our two key recommendations or insights, I just want to make sure that we're all broadly on the same page. Of course, we should celebrate longevity. It's one of the greatest, I think, achievements of humankind. But equally, as we age, of course, that places into stark contrast some of the failures in systems and nations around the world. And as you can see from this slide, whilst our life expectancy has increased by 25 years globally since the end of the Second World War, we still have life expectancy of 45 or 46 in Sierra Leone, and of course in Japan at 84 or 85. Interesting to note that the South Koreans have just taken over the Japanese for the world title for the longest living population. We also know that lots of people die prematurely, and I don't need to tell this audience that that's a blight on humanity. But when we started to think about what produced some of this misalignment, we decided to go into deep discussion with our private sector partners, our public sector partners, NGOs and also charities. So the hypothesis, as you can see here, is that misalignments among stakeholders significantly contribute to the underperformance and waste within the health sector. And Adrian Goy, some of you may know him, a very influential oncologist and cancer doctor in America, also a member of our World Economic Forum Health Council, describes misalignment as fundamentally a disconnect between the interests and objectives of different stakeholders and players. No surprise there. But once again, just to reiterate my central point today, if we all know that's a truism, why don't we spend much more time, effort and research on reducing those misalignments? Now, I'm not really going to plug my book today. It's a bestseller. We have left 20 copies upstairs if you want to get one for free. If you want to pay for one, I've waived all of my royalties to Prostate Cancer UK. So if you feel good about yourself, go buy the book. If you don't, you feel cheap and nasty, just take one upstairs. Now, the reason I mention that is, as you could see from my first slide, I've had the privilege of working in 69 countries. And one of the chapters in my book is called The Paradox of Change. And fundamentally, I make a very obvious point, which is if you can better align payers, providers, pharma, patients, and others, you get much more value in the system. Now, what we did to test our hypothesis, and you can see that we also discussed and talked to Imperial College, we spent 18 months conducting 60 interviews in 16 countries across 6 continents. So as far as you can get a global sweep from different stakeholders in different parts of the world, we had a very good go at it. Now, what's interesting, of course, when you have these interviews, somewhat detached, admittedly, from the hurly-burly, the cut and thrust of paying or providing or regulating healthcare, people tend to be a little bit more honest. And these misalignments, as you can see here, I'm not going to go through each one of them. I'm sure in your own professional careers you bumped up against at least, if not all of them, certainly the vast majority of them. And we talked and modelled 3 different care diseases to see what the benefits of alignment could produce. And the 3 areas we looked at were cancer, diabetes, and mental health. So we didn't choose necessarily the easiest ones, nor indeed the sexiest ones, arguably with mental health being included. What were our 2 major conclusions? By the way, if you're interested in the research, it's on the World Economic Forum website. We concluded 2 things. The first one, I don't know whether you'll find it that surprising, although personally I was surprised. The second one I think is a little more stunning. The first one is that when you look at cohorts and deciles of spending groups of countries, and you basically assume that those spending groups in those deciles can raise to upper quartile or upper decile performance. So I'm not arguing that Sierra Leone can ever be the United States of America. We're taking basically similar countries with similar health profiles, with similar health patterns of provision, and we're saying, what if they raise their game to the upper quartile and then the upper decile? And the conclusion we came to, and this was work that David Bloom did with his team in Harvard, supported by our economists from KPMG, the conclusion is you can get, on average, an extra 4 years of life if you improved each cohort, each national cohort's performance. Now, of course it's abstracted, of course it won't happen, but by asking that question, instead of always thinking that we need more of everything, why don't we think about innovation in business models that get more out of what we've got? If we did, and that doesn't seem to me to be an unfair or unreasonable assumption. And another matter I raise in my book, I don't know whether I mentioned my book or not this morning, is we, of course, in KPMG, we span 21, 22 different sectors, but the degree of competition and collaboration in energy or telecommunications or pharmaceuticals or indeed academia for that matter is much greater than the degree of collaboration in global health. We have great, fine global health institutions, Bill and Melinda Gates, the World Health Organization, but no institutions really exist or dominate this quest for better business processes and care models across the world. Changing American healthcare systems, for example, we're working in New York State, 21 million people, trying to create accountable care. The mechanisms and principles for doing that are just exactly the same as doing it in the Netherlands, or indeed doing it in Singapore, or indeed in the United Kingdom. So the conclusion, the first conclusion of our research, it's all, I think, meticulously documented for those that want to read the document, the paper, is that if we raise performance to the upper quartile and then upper decile, we would, for the same amount of money, it's about 9 trillion now, but we won't quibble, 7.59 trillion, we've been talking for at least 10 minutes, is 4 years of extra life expectancy for all human beings on the planet. Now that's worth having. The second conclusion, I think, is more stunning. if you wanted to maintain the same life expectancy globally, you could do that for 33% or a third of the current costs. Now, I'm not clearly arguing, by the way, a lot of the waste is in the United States of America, so that skews it quite considerably. I'm not obviously arguing that the United States should give 2/3 of its health expenditure to Sierra Leone, but I am making the point that if you wanted just to maintain, you could reduce costs and eliminate waste by reducing divergent interests and stakeholder misalignment. So, the three areas that we concentrated on, looking at, as I said, cancer, diabetes, and mental health, were these three areas. And these three areas account for a lot of waste in any health system, both in the developing and the developed world. Divergent objectives, power asymmetries, and cooperation failures. I know of no health system, unfortunately, possibly with the exception of China and Singapore, for completely different reasons, that thinks anywhere beyond 3 years in a cycle of health, reform, and innovation. It's a very sad fact. Health, as you know, when coupled with life sciences, is the second largest industry on the planet after agriculture. And it stuns me that we have no critical thinking of any seriousness that extends beyond 3 years. So the first point to make is there is no long-term sustainable vision for how misalignments can be reduced. You can argue that Obamacare, for example, tried to have a go in the United States. You can argue that the 5-year forward view is trying to have a go in the English National Health Service. You can argue that the new clustering arrangements in Singapore are thinking about the future in terms of ageing, but there is no country that really can hold its head high when thinking about systematically reducing these misalignments. So in my own humble way, I call in my book for a new global organisation, perhaps it can be facilitated and powered by Imperial, to think about exporting best practice in business model innovation. We do it in plenty of other sectors, including financial services. Why shouldn't we do it for the second largest industry on the planet? You can see here, and some of these slides obviously are bullish. They make very blunt points just to exaggerate my argument. So you look in the OECD, for example, in terms of health expenditure on cancer. It's not quite a case of they who shout loudest get most. But you can see what's spent in research is not what's actually killing people. Now, there are lots of different reasons for that. We all know the issue about smoking and lung cancer. But that's just a very simple point about where research is being misaligned from health need and health benefit and extended quality-adjusted life years. An easy point. The more profound point, as I say, is in the maroon behind me, where, and I'd ask you to think about this from your respective countries. We've got a pretty good spread today. Can anybody think of any country that's got a meaningful 5 to 10 year plan for healthcare, which combines the impact of education, crime, insurance, healthcare, governance, and the rule of law? It wasn't a rhetorical question. Any takers?
Yes, there's several actually.
Okay.
Yes.
Which one would you highlight as being probably the best?
Well, I think Turkey has introduced excellent health system reforms with massive reductions in health outcomes, improvements in financial risk protection and user satisfaction. And they achieved that just in a period of 8 years. Malaysia has just embarked on a very ambitious health system reform. I could go on.
Yeah.
But so there are several that are actually...
Yeah.
And there are also those... I worked in a country that has a health strategy to 2050. What is the strategy?
Good. Well, on Malaysia, of course, that reform has been a long time coming, so let's hope that they're going to now expeditiously implement that after all of the political turmoil over the last few years. We wish them well. I'll put some money that they don't achieve their objectives, but we'll have that bet later on. Secondly, power asymmetries. You can see here that only, according to the World Health Organization, only 10% of the world's population live in a country with a tobacco tax, for example, that is sufficiently high to compensate for its social cost. And secondly, as I said here, you look at the funding behind different tumour sites, and there is a clear mismatch. Cooperation failures are, I think, probably the biggest example of asymmetry that I find when I go about my work around the world. And quite simply, there is too much short-termism between a payor and a provider. So there's no concentration on the pursuit of value. I know it's a hotly debated subject, whether you're a Porterite or some otherite. Basically, the lack of, I think, systematic attention to the pursuit of value over, say, a meaningful period, which would be 10 years, I think is stopping us actually align incentives or sufficient incentives in the short term. And this is just one example here where we talk about cost shunting between health and social care. It's good that we've got Ian Smith here today from Four Seasons. I know that he's speaking later on. And clearly that's a big issue that's occupying the attention of policymakers and politicians in the United Kingdom at the moment, but equally looking at cooperation failures between clinicians and patients. So thinking about how far patients can actually help to cooperate with their physicians in taking more self-care into their own control and their own hands. Having said there are no countries, in my opinion, that have a systematic plan to reduce misalignments over a sufficiently long and sustainable period of time, I don't want to be too depressing. There are great examples of cooperations across the world. And here I just mentioned 3 or 4 of them, whether it's in Brazil, in Singapore, in Israel, or in Australia. And I haven't got time today, unfortunately, to talk about some of the more successful characteristics that I've seen. But one system that does very much impress me is the Israeli system. Now, as you probably know, in the early part of the 20th century, the sort of workers' movement in Israel created a number of health maintenance organizations. They, I think, are more sophisticated or smaller in scale than some of the more noteworthy ones in the United States. But if you take just one, for example, Clalit, that ensures 52% of the population of Israel. What is nice about their health system is that they have 4 integrated HMOs. So they're both payers and providers. And ever since about 1915, 1916, they have consistently invested in prevention and also in primary care. Now, there are problems with the Israeli system in terms of the pressure on its hospital sector. It has a very small, relative to per 10,000 population, number of acute beds. But their system is fundamentally established to think about prevention and primary treatment. And of course, the results, broadly speaking, 7.8% of GDP for average life expectancy of 83 or 84 years of age, stand up well and against good global comparisons. There are 2 or 3 other things that I just wanted to say about the Israeli system, which help to illustrate this issue about reducing power asymmetries or misalignments. The first one I would say is they spend a disproportionate amount of their national wealth on technology, partly because of the defence industry, which we all understand, but also because of care. 57% of paediatric consultations in Kuwait take place on the smartphone. It's a good example of how you're reducing the asymmetries of power between a doctor and a patient, but also reducing that costly and fragmented supply chain. That's just one example. The second example is that most of their diagnostic capability is housed in community or ambulatory settings and not warehoused or fossilized in big teaching hospitals. And the third issue to say is that their research and development capability is closely connected to the economic prosperity of their country. Now, I'm not claiming it's perfect. You wouldn't believe me if I did. But they are thinking more broadly about the determinants of health and reducing some of the misalignments that cause waste in a health system. Finally, in my book, I say there is no such thing as the perfect health system. My second book will be called Still Searching. But what I've tried to do here, and I can't go through these examples, is look at the 12 things that have struck me as being very powerful contributors towards a better or indeed a near perfect health system. In conclusion, if we could reduce some of the misalignments that stakeholders tell us they fight against or with every day, And if you generally accept that the work that Harvard and ourselves did are in 16 countries looking at payers, providers, pharmaceutical companies and patient representative groups, my challenge today, or my question today, which I think hopefully fits with the theme of the conference, is of course we'll end up spending more money in healthcare. That's right and proper for every civilized country that's developing. But there is much more that we can do to reduce and eliminate waste to create better value in our health systems. And I would humbly call for better global cooperation in terms of looking at business models in healthcare that work, and think about academic and business and other groups coming together to make sure that we can perhaps more sustainably and more evenly spread what works across global healthcare. Thanks very much indeed.
Thanks, Mark. That was a fascinating talk and a great introduction to the day, I think. I know there are themes in there which we're going to pick up around business model innovation later on. So that was excellent. I think we've got time for just a couple of minutes of questions if anybody has anything. Yes.
So Mark,
Could you say who you are, please?
yes, Dominic Five, the Sound Horizon. So we're the boutique consultancy. We work with a variety of different players in the space, including pharma, government, and small wearables providers. So, first of all, there's a rumour that you've got a book out. You've just achieved a sale on Kindle while you were talking there.
Thank you very much indeed.
Power of immediacy.
Prostate cancer, thanks you.
So I wanted to just pick up on the cooperation failures that you outlined, and obviously there's a huge amount of waste going on there. With cooperation failures, a lot of our clients and people we talk to, they say that they would love to cooperate, but the medical establishment is surrounded by risk aversion, total and utter risk aversion. They're scared of even picking up the phone and talking to different players in the ecosystem. And I wanted to see if you had a perspective on that, first of all. And secondly, to ask you, do you think that the innovation that is necessary will come from outside of the health systems through small innovative players as it is in financial services and entertainment and communications?
The answer to the first question, I'm pleased that Steve Smith's here with us today, Professor Steve Smith, who I think is a globally great example of an innovative clinician. So I would say, yes, by training, thank goodness, clinicians are trained to attend to the detail and think about risks. And I think as a cancer survivor myself, I'm pretty pleased that that attention to detail and that degree of risk aversion has helped save my life. However, I do believe it's possible to hold two different attributes in your brain at the same time. And fortunately, most clinicians are hyper intelligent. And therefore, I think it's about the way that they've been nurtured, not natured, in terms of actually starting to develop new cadres of clinicians. We know that our research scientists, that many of our clinicians that work with pharmaceutical industries have a high degree of restlessness and curiosity. So I don't believe that it's the clinicians that are the problem. I think it's the system in which they're educated and managed and work that actually destroys that over a period of time. I once had the privilege for 8 years of being the chief exec at the University Hospital Birmingham, and I remember my old medical director. I was 34 at the time when I was appointed, and my medical director was 62, so just older than you, James. And he said, the problem that we find with doctors in the English National Health Service, we appoint them at the height of their brilliance and watch them become bitter over 30 years. But enough about Steve Smith. Let's move on from that for now. But so I think it's about something we do to them and something that happens to them during the course of their career. So fortunately, the good news is there is quite a bit that we can do to rectify that. In your second question, when I was Director General of the National Health Service some years ago with Lord Darcy, of course, we looked a lot at innovation. And I think the simple answer to your question is you need both. You need a very strong government strategy, which does have some pump priming capability in terms of investment, but you do then need to create a much more fluid and I think permissive environment for startups and small businesses to thrive. And I have to say, honestly, with the exception of Silicon Valley and parts of the United States, Israel is the country that gets that right more often than any other country I've seen. Singapore's coming up, but the Israeli system is awash and alive with investment, technology and capability. So the answer to your second question is, yes, I believe you've got a very strong role for the future.
Good. Okay. Well, so many things to discuss, but so little time. And Mark, thanks very much.